meeting called Advancing Measurement of the Scale and Reach of HIPs. I'm very happy to welcome you all today. Next slide, please. My name is Trinity Zan. I'm going to be your overall MC for the day, moving us through our very exciting, very packed agenda. I'm the Deputy Director for the USAID funded Research for Scalable Solutions project. Next slide, please. I'm going to give you a brief overview of what we have today and a little peek into the future. So we are actually today part of a two-day convening that is taking place today and tomorrow with a similar overall objective, as I mentioned, or as you might have inferred from the title. But the objective is really to identify how we can improve routine monitoring of scale and reach of HIPs through national and program information systems. And today, we're talking about immediate postpartum family planning and post-abortion family planning as part of the broader postpartum family planning umbrella. And tomorrow, we'll be talking about community health workers and pharmacies and drug shops. At the end of these 2 days, we hope that we will have considerations and recommendations for strengthened monitoring of the scale and reach of these HIPs. It is feeding into an even larger process. So in another few weeks, you will likely hear from us about a second round of a convening that is similarly focused on strengthening measurement of HIPs. But in this case, we'll be talking about the quality of implementation. So that should be really exciting. Stay tuned for that in another month and a half or so. But back to today. You have a little snapshot of the agenda. It feels long, 2.5 hours, but I promise you it's going to go by very quickly because we have so much that we want to talk about. But before we do that, I know my colleague Sarah has put some questions for you to introduce yourselves in the chat, but we also have a couple of polls that we'd like to launch just to see who's in the virtual room. So I'll ask my colleague Sarah to please go ahead and launch the first poll. And hopefully this is something very easy for you to do on the screen. The first question will be asking you where you are connecting from. And I arbitrarily chose these areas. So if you're angry, you could be angry at me, but are you calling in or dialing in from North and Central America and the Caribbean, from South America, Europe, Africa, or Asia and Asia Pacific? And happy in the United States, it's Asia Pacific Islander Heritage Month, so happy that. So go ahead and answer that question, and then we'll see who all we have in the room. All right, Sarah, when you think there's a good number of responses, go ahead and show us the results. Okay, we are dominating from North and Central America and Caribbean, but I'm enjoying our 26% from Africa and 12% from Asia and Asia Pacific. So thank you for that. And next poll, please. This one will be asking a little bit about the organization that you primarily represent. So are you associated with a Ministry of Health, with a donor, with an international NGO, a national or local NGO, or maybe some other type of group? We would love to know. So we'll give you a little moment to take those polls. And then we will see again who is in the room. All right, let's have a look. Okay, we've got a pretty good spread. Mostly international NGOs, a little less than half, but we've got, I'm loving 25% others, so I'll be paying attention to the chat and see where you all are working and who you're associated with. Just a little bit on protocol. If we, I think for bandwidth, we'll largely keep our cameras off. I'm going to keep mine on as I'm going to be doing more talking. When our speakers come on, we'll ask them to put their cameras on, but otherwise we'll try to minimize that. And similarly, unless you're speaking, if you would stay muted. And we are excited about today and the way that we structured this to allow a really good block of time for interaction and engagement through breakout group discussions. We will not really have time outside of that for questions. So apologies in advance. If you have questions for some of the speakers, you can always put that into the chat and they will try to have a look and respond. But we are looking forward to those breakout group discussions, which will hopefully allow us the chance to get a little more intimate and a little more deep into our technical content. All right, next slide, please. Before we do go and get further into it, I just wanted to acknowledge the many organizations who have been a part of preparing for today and tomorrow's convenings, represented here on the slide as organizations. And then next slide, please, through a number of people who have made up a planning committee that has been also helping to plan this convening and the one that I mentioned that will come again in the future. So a huge thank you to all of these people. Next slide, please. So I'll just do a little bit of framing for the day, and then I will be handing it over to our opening speaker. But really today can be thought of as situated in or grounded in the HIP initiative. I think many of you are familiar with the HIPs, but if you're not, the HIPs are a set of practices which have evidence of positive outcomes, namely uptake of contraceptive use, and have been vetted by a group of experts and summarized into a series of briefs. The HIP initiative has been around for about 14 years now and is really looking to improve the quality of overall family planning programming and policy. There are a number of co-sponsors, many of whom are with us today, and we're very happy about that. And so specifically today and tomorrow, we'll be talking about a few select HIPs. If you would go to the next slide, please, Emily. I just wanted to make sure that we all have these in our heads. Out of the many HIPs that are there, today we are talking about immediate postpartum family planning, and you'll see the definition there on the screen, offering contraceptive counseling and services as part of facility-based childbirth care prior to discharge from the facility. And post-abortion family planning, again, you can see the definition there, but offering voluntary contraceptive counseling and services at the same time and location where women receive facility-based post-abortion care. Again, these can kind of be thought of in a broader umbrella of postpartum family planning, and different speakers today will be talking about the big picture of postpartum family planning and then zooming into these specific HIPs. So with that, please, let's go to the next slide, and I will introduce our opening speaker, Jason Bremner, who is the Senior Director for Data and Measurement at FP 2030, and I will hand it over to Jason now. Over to you, Jason.
Thanks, Trinity, and thanks everyone for joining this morning for me, afternoon, or possibly evening for you. I'm just going to take a few moments, if you could move to the next slide, please. To give some context on how we arrived to where we are today. Actually, the conversations about measurement of the high-impact practices go back to the early days of creating the high-impact practices and thinking about ways to measure these outcomes, some of which are relatively easy to measure with our standard tools, and others that are more challenging. This conversation about measurement of scale and reach and implementation of the high impact practices has continued and continues today. Sometimes it's a broad conversation, and sometimes it's a specific conversation on particular high impact practices. In a meeting just last year in Nepal, 16 country delegations, along with FP 2030 and many technical partners came together to work with countries to assess their progress on scaling up postpartum and post-abortion family planning. And as part of that convening, which took place in Nepal, We discussed measurement challenges and continued measurement challenges since these early days of conversations about measurement of in particular postpartum and post-abortion family planning. If you could move to the next slide, please. Within the Nepal postpartum and post-abortion family planning meeting, we had a particular measurement focus and measurement sessions that focused on identifying continued challenges in postpartum and post-abortion family planning measurement, including challenges around data collection, alignment of definitions and indicators, and gaps in what is currently being measured and what is desired. We focused largely in that meeting on the measurement of scale-up outcomes, or the outcome of postpartum and post-abortion family planning scale-up. That is the use of services and the counseling on services, as opposed to how you might achieve that outcome. And as Trinity mentioned, there'll be future meetings later this summer for us, later this summer, to talk about the implementation and how one might measure that. So in these conversations, next slide, please, we explored lots of different ways in which you might measure postpartum, immediate postpartum, and broader postpartum family planning, as well as post-abortion family planning, post-abortion family planning measurement. So ways in which we did that. We had presentations on how you might use survey data, such as the demographic health survey or the mix survey, and contrasted that with how you might use regular service statistics, HMIS data, or health management information systems. We then dove really deeply into the postpartum family planning and post-abortion family planning elements that are available in registers and HMIS systems. And we're going to actually see a lot of those presentations and analysis today. So I'm really thrilled that we'll be really sharing the outcomes of that Nepal meeting and analysis, and that will lead us towards examining and identifying issues and challenges around these HMIS components. There was a lot of country-to-country learning, and a lot of countries coming out of that Nepal meeting had priority actions in their scale-up plans that focused on measurement and data. Next slide, please. These are some of the countries at that meeting that did focus on measurement actions coming out of Nepal, and are working on improvements to either immediate postpartum family planning or post-abortion family planning registers, reporting of data, alignment across different registers. So a lot of work going on this, and we are focused in country interactions on the progress on that. But there were also a series of global actions or opportunities for action that were identified at that meeting. Next slide, please. One more. And I want to focus here on the left side. First, we really wanted to disseminate, coming out of that meeting, disseminate the postpartum family planning and post-abortion family planning HMIS analysis to a wider audience. And that's one of our objectives today. So really thrilled that this is happening. And I want to thank all of the organizers of this meeting, who also, many of whom contributed to the Nepal meeting and are taking action on these next steps. And the third bullet on that slide there to the left is to consider updating HMIS recommendations. And so I should stop there and say that in 2018, in this conversation about measurement of high impact practices, and particularly around immediate postpartum family planning, a series of HMIS recommendations were developed after consultation with countries, after analysis and examination of what countries were doing, and a set of recommendations were developed. These are not perfect recommendations, but at the time they were the best we thought we could do with existing data and existing systems. And so today we really do want to spend some time examining these, gathering input, and thinking about what should come next. So I believe in the next slide, before we introduce those indicators, we're going to do another poll. So I'll turn it over to the organizers to launch that poll. Okay, so the poll here is, were you aware that there are existing globally recommended indicators for immediate postpartum family planning and post-abortion family planning? So you've got a yes, a no, and an unsure. Go ahead. I've got to respond as well, so let me contribute. We'll give you a second. Only 3 responses there, so I hope you'll answer that. And when organizers are ready, we can go ahead and launch the results from the poll. Great, okay. So about 2/3 of you are aware that there are these recommended indicators for immediate postpartum family planning and post-abortion family planning. About a quarter or a third of you weren't sure or aren't aware of them. So we're going to spend a lot of time on these today. So let's go ahead and close that poll, and we'll move to the next slide.
Sorry, we had one more poll. I'm sorry to interrupt.
Oh, one more. I'm sorry. Thanks.
It's a surprise poll. Sorry.
No worries. No worries. Let's add one more in here. Okay. Thanks for the reminder on that. And do you think these indicators are being used in your country or in your project? Because they could be used by an organization doing a project and collecting this data through clinics or through particular public sector clinics that they might be working with. So do you think these recommended indicators are being used in your country or your project? There. And whenever you're ready, we can launch the results of that one. Okay, so those recommended indicators, about 2/3 were aware of them. Here we can say the majority, 40%, are unsure about whether they're being used in their own country. About a third, a little less than a third, are saying they are being used, and then a third saying no. And this is a reflection or one of the challenges we identified through the analysis and that you will see, which is some inconsistent use and knowledge of these indicators, and that's what we want to address today. Where should we go with these? Are they okay as they are? Should we improve them? How do we get them used, or other indicators used more consistently across countries and projects? So happy that I think if we had found that this said yes to 100%, we would feel like the objective of this webinar perhaps we're misaligned with the group here, but this matches perfectly with what we have planned for the day. So let's, with that, I think we can move on to the next slide, and we'll introduce these indicators that are going to be a part of the conversation today. So next slide. Okay, so I was part of a group, and I know several others of you joining the webinar today also participate in this group that came up with these recommendations. A longer document that describes the process and has a lot more information is available, I think was posted in the chat, so thank you for that resource, but here they are. For immediate postpartum family planning, there were 2 indicators that were recommended. One is the number and percent of women who deliver in a facility and initiate or leave with a modern contraceptive method prior to discharge. So we are talking about immediate postpartum family planning. And that could be disaggregated by, or should be disaggregated. The recommendation says it should be disaggregated by type of method and age group, and these being some broad age groups of under 20 years or 20 years plus. So this is really about leaving the facility after birth with a modern contraceptive method. The next is the number number/percent of women who delivered in a facility and received counseling on family planning prior to discharge. So many women may not want to immediately leave with a method, but the system, in a rights-based system, should be providing all with counseling. And so this is about number of women who received or delivered in a facility received counseling on family planning prior to discharge. Again, same disaggregations. So that's one set. The next set, post-abortion family planning. Again, the number/percent of post-abortion clients who were counseled on family planning. Again, disaggregated by age group. And they're specifically, again, less than 20 years and over 20 years. And then the second being a use indicator, the number/percent of post-abortion clients who leave the facility with a modern contraceptive method. And they're disaggregated by type of method and again by age group. So these were the recommended indicators. Just a word on the number versus percent, and we'll see this when we start to talk about the HMIS registers. The register is capturing a number of clients. To get that percent, you would need to know the number of people who had actually been in that facility to receive, who had delivered in the facility or who had received post-abortion services. So you would need a denominator. We're going to have conversations, I'm sure, in the small groups about denominators. So with that, I'll turn it back to Trinity, and she'll take us through the rest of the webinar. Thanks, Trinity.
Thank you, Jason. That was an excellent introduction. Thank you for reminding us of the history. So again, knowing and recognizing that this is not the beginning of a conversation, this is very much the continuation of a conversation that has been going on for some years, and excited that we can help move that forward today, and also giving us so much important contextual information. And I just want to emphasize the importance of the learning and the sharing. And so again, we're looking forward to doing that in the context of these breakout groups. So I will move us then to the next session. Having heard some of that history and context from Jason, we want to continue that by offering some additional information about what we're kind of calling the universe of data that exists within HMIS systems and among projects and partners for monitoring scale and reach of these two HIPs. So I'm doing throughout the course of today very brief introductions to our various speakers. We'll make longer bios available after the fact, but I'm very pleased to welcome these three wonderful women. Susan Petrick, who's the Data for Impact Partner Lead at ICF. She'll be followed by Deb Citron, the Momentum Country and Global Leadership with Japigo, and Priya Emart, who's the Deputy Director for Track 20 at Avenir Health. So we'll just move from one to the other. And again, a note that we won't have time to hear questions, but if you have some specific questions, you can put them in the chat and also hold on to them for the breakout group discussions. So with that, I'll turn it over to Susan. Welcome, Susan.
Thanks, Trinity, for that introduction. I appreciate it, and it's nice to be here with everybody. And I will be sharing just a few slides about work that was done to identify HIP indicators being used. And this work was carried out by 3 different projects. Specifically, as Trinity mentioned, I'm with the Data for Impact project. And then, of course, the other 2 projects are the SMART-HIPs project and the Research for Scalable Solutions, our R4S project. And for this presentation, we've combined the findings across those 3 projects. And next slide. D4I and SMART-HIPs R4S conducted a similar exercise of collecting HIP indicators that partners report on. D4I worked in Bangladesh and Tanzania, and the SMART-HIPs R4S conducted the activity in Nepal, Uganda, Burkina Faso, and Nigeria for the IPPFP HIP, and Mozambique and Nigeria for the PAFP HIP. And throughout this session, you've heard us start with the term partner, and noted here specifically what we mean by the term partner. In the case of D4I, this means specifically USAID funded projects. whereas for the SMART-HIPs R4S, it's cast a bit bigger net in terms of referring to both some USAID projects and UNFPA funded projects, as well as various NGOs, INGOs, and CBOs in those countries that are supporting HIPs implementation. In both cases, there was a similarity in how the work was undertaken, in that partners filled out a spreadsheet describing the indicators they collect. From the list of indicators, duplicates were identified. Further, a list of unique indicators was established by collapsing similar indicators that measured the same concept, despite using slightly different language and are having different disaggregations. So next slide. On this slide, we use the funnel graphic here to help convey one of the main findings from the indicator inventory exercise. And that is simply that partners collect a wide variety of indicators, and that those can be distilled or funneled down to just a few unique indicators. And some of the indicators were common across the partners, although at the same time, in many cases, the many indicators are unique to just one specific partner. And just again to note that the IPPF HIP, for the IPPF HIP, the indicators were identified by D4I and SMART-HIPs R4S, but for the PAFP, indicators were identified only by the SMART-HIPs and R4S. So next slide. This slide shows the full list of deduplicated and unique indicators for IPPFP and PAFP collected by SMART-HIPs and R4S, as well as the full list of IPPFP partner-reported indicators collected by D4I. And the D4I indicators are mapped to the most relevant deduplicated indicators. As shared on the previous slide, what the end result is 12 unique indicators for IPPF and PAFP, of which D4I project shared 6 of the unique indicators. So this sort of the top half of the table. You see the list there. Next slide. A number of things were learned from this exploration of what indicators partner use for the two HIPs. First is the idea that indicator definitions really varied quite a bit, and this was particularly the case in terms of what counts as the immediate, within IPPFP, and in terms of the window of time where a woman is considered postpartum. The inconsistencies, such as these and others, were generally visible through the deduplication effort. For example, if you note the blue box on the right, this lays out how deduplicating worked. And so you take at the top, we've noted what the unique indicator ended up, number of IPPFP users. So, but establishing that as a unique indicator came about by collecting similar indicators that measured the same context. These are listed as well, the illustrative submitted indicators. These are the deduplicated indicators. In addition to looking for inconsistencies in terms of language, it was also important to understand what disaggregations were being undertaken, how the data flows, and how the indicator is calculated. Next slide. A second key finding is that it was generally the case across the partners that HMIS reporting is more the exception than the norm. Some of the possible reasons include that indicators are frequently not being reported into the national data system, or those that are primarily useful for improving HIP implementation at the program or local level. Also, some indicators are used to inform broader programmatic goals, and these can sometimes also be used to understand HIP implementation, especially when disaggregated or serving as a denominator. In the blue box on the right are some indicators from the partners that they use, but these are examples of partners noting that these indicators are used, but they are not reported into an HMIS. Next slide. As we've heard from the opening speakers and things, we've all convened at this webinar given a shared interest in the indicators used to monitor and implement HIPs. And we have interest in increased harmonization and aligning to global recommendations if those exist. And in the top half of the slide, I've again noted the global recommended indicators for the IPPFP and the PAFP HIP. And just again to note that these indicators are pulled from the HIP briefs. In addition, these indicators have been recommended via a process initiated by the PPFP community of practice and subsequently shared and endorsed broadly. With the D4I and SMART-HIPs R4S work, a key question that we looked at through that work is, do the partners use these globally recommended indicators? And I would say that the findings were a bit mixed. In particular, it was challenging to determine if partners collect all of the data necessary to report fully on the globally recommended indicators. It was fairly clear that most partners collect data on pieces of the globally recommended indicators. Some of the challenges to aligning to these recommended indicators include method uptake is commonly reported for PPFP, but the timing of that uptake is not as commonly reported or collected, and that wouldn't be needed to measure IPPFP. Counseling services are difficult to with limited focus on quality of counseling. Age disaggregation is reported by some partners, but not necessarily the disaggregations per the globally recommended indicators. Method disaggregation is reported by some partners, though disaggregations vary such that reporting on individual methods is not always possible. Next slide. I'll end with this slide, and just to note a few sort of key summative takeaways. It's clear that partners monitor HIPs. However, there's a lot of variation in terms of the indicators that are being used. Often seemingly comparable indicators are not similarly worded and do not have consistent definitions. Most partner data are not connected to the national data system via HMIS. And overall, there's some alignment with global recommendation, but gaps still exist. So thanks so much for your time. And with this, I think we'll move straight to Deb's presentation. Thank you.
Thank you, Susan. Yes, and Deb, invite you to come. And again, we're trying to keep to time, so about 10 to 12 minutes. Thank you.
Great. Thanks, Trinity. Thanks, Susan. So I will be sharing findings from 2 reviews of country HMIS tools. One by Momentum Country and Global Leadership that was done for the FP 2030 workshop this past November that Jason mentioned, and another subsequently done by R4S and SMART-HIPs. Before I start, though, I do want to quickly note that even though these reviews were pretty recent, it's really hard to keep this kind of review current. And I would not be surprised if someone on this webinar sees something that doesn't match with their experience. So we do welcome comments and for people to share updated tools if they have them. All right, next slide, please. So the purpose of these reviews was not just to take a full stock of what's collected, but also to, again, compare to recommendations that exist on what countries should collect related to HIPs. Jason already mentioned the work of the PPFP community of practice several years ago, but I just want to quickly revisit the 4 recommendations from that time. So one was that all countries should collect PPFP uptake prior to discharge after birth, which, as we heard, is now in the IPPFP HIP brief. 2, that countries may collect FP counseling prior to discharge, although the counseling was seen as a lower priority indicator compared to the uptake one. But this indicator was also included in the HIP brief. 3, that ANC registers or cards should document if FP counseling and method choice was made during pregnancy to help facilitate services, but that was not a priority for reporting upstream. And 4th, that there is need for a recommended indicator for PPFP beyond the immediate, but there was just insufficient evidence or consensus at the time to select one. So next slide, please. So here again are the recommended indicators that are in the HIP briefs for IPPFP and PAFP. But since we've already seen them a couple times, I'm just going to breeze past this and we can go to the next slide. So the scope of these reviews included what's recorded in registers and what's reported in the summary form the facilities use at the end of the month to sum and report their data. We did not look at client charts, electronic individual records, what's in DHIS 2, or what gets ultimately included in reports or dashboards. Next slide. Okay, thank you. Since FP services can be offered during pregnancy and through the first year after birth, there's many contacts over that period and many different places where data could be recorded. So we reviewed the 5 registers shown here for all the countries in our review, but we did not examine registers for child immunization, nutrition, well or sick child visits, because from experience, PPFP is not typically captured in those tools. So we probably didn't miss a whole lot, but did want to show what we included in our review. Next slide. And lastly, here's the list of countries in the review. 15 were done by MCGL and 5 by R4S and SMART, but because of some overlap, the total is 18 countries. All right, next slide. So let's just go right into the PPFP findings. So first, let's look at whether PPFP counseling at various time points is recorded in the registers. So we looked at 4 different time points, and as shown in the bottom row, registers in 7 countries have space to record counseling during antenatal care. Registers in 8 countries record counseling before discharge after birth. Registers in 11 countries record counseling during postnatal care or within 6 weeks. And registers in 4 countries record counseling but do not specify timing. Next. Overall, 14 countries record counseling during at least 1 contact, and 11 capture counseling at more than 1 contact. Next slide. So now we can see which pieces of this data actually get summed up and reported by facilities. So the boxes that have turned dark are data that go into that monthly summary form. From the remaining checks, it's evident that much data that's recorded in registers on counseling doesn't get reported up. You hit next. And next. So overall, 7 of the 18 countries report at least 1 data point on FP counseling. Next. And 1 country reports counseling at more than 1 contact. The column that's highlighted here, that second column, is the indicator recommended in the HIP brief. Only 2 countries actually report that up, and just as many facilities just as many countries have their facilities report up counseling done at some other time point. All right, next slide. Moving on to PPFP provision. So this is actually giving the methods. So we see again at the bottom the number of countries where PPFP provision is recorded. So registers in 13 countries record FP given pre-discharge. 10 countries record within 6 weeks, 5 countries capture within 1 year, and some use a different or open time frame, or the time frame isn't specified in the tool that we reviewed. Next. Overall, every single country in the review records PPFP provision at some time point. Next. And in 13 countries, they record PPFP provision at more than 1 time point. All right, next slide. Now we again see what's reported. So again, what turned dark is what's reported. Next. All 18 countries report PPFP provision at some point. Next. And 8 of the 18 countries report PPFP provision at more than 1 time point. Next. And again, here I've highlighted the recommended indicator, and note that just as many countries report PPFP provision later in the postpartum period. All right. Next. Okay. This slide now shows what registers are used to record PPFP provision and what timing is included in each register. As you can see, a lot of registers, they record just 1 time point, and in some registers, they record multiple time points. And in many countries, the same timing is captured in more than 1 register. Occasionally, there's directions on how to use each tool. For example, in Ethiopia, you see that immediate PPFP is captured in both the delivery and the PNC register, And there is a footnote in each of those registers that register should only record women who get FP in that particular ward. But using multiple different tools to capture the same timing does introduce the possibility of undercounting if just one of the registers is referred to when somebody tallies the results for the form. Or there also could be double counting if data are summed from multiple tools and the same woman is recorded in multiple tools. So recording in multiple tools does introduce some complexity that could result in either overcounting or undercounting. Next slide, please. Now we look at disaggregation of immediate PPFP by method as recommended in the HIP brief. Only 4 countries have summary forms that separate out IPPFP provision by all methods. I did not include Nepal in that count because the report disaggregates by IUD, implant, and sterilization, but not pills, condoms, or other methods. In quite a few countries, Kenya, Nigeria, Sierra Leone, Zambia, registers do capture any method, but it just doesn't get disaggregated once it's reported up. Meanwhile, in some countries like India, Mozambique, the registers only allow for recording one method that postpartum women can receive immediately after delivery. So for example, in India, they only capture immediate IUD provision, but they just don't capture any other methods if women get that after birth. Next slide, please. As for age disaggregation, only one country disaggregates IPPFP data by age in their report form. Age is always captured in the registers as long as IPPFP is recorded, but it's just not disaggregated in the report. Next slide. So quickly, let's move on to post-abortion FP data. FP counseling during post-abortion care is recorded in registers in 7 of 18 countries, and method provision is recorded in 14 countries. Next. Only one country reports the PAFP counseling in the monthly summary form, and 9 countries report method provision. And again, both of these indicators are recommended in the HIP brief. Next. When it comes to disaggregating by method, 6 countries disaggregate by most or all methods. Again, in India, only provision of IUDs, permanent methods, and condoms are recorded and reported during post-abortion care. And in Tanzania, all methods can be recorded, but the report only includes implants and everything else gets lumped as other. Next slide. And in 4 countries, PAFP provision is disaggregated by age in the monthly summary forms. Next slide. This is my last slide. This just summarizes all that I quickly, very, very quickly went through. But this slide summarizes how our findings compared to the 4 recommended indicators. As you can see from this, many countries do collect this data in their registers, but far less gets reported upstream. And even fewer countries disaggregate by method and by age. So with that, I'll say thank you, and I'll pass on to Priya, our next speaker.
Thank you, Deb. Thank you so much. I know that was a lot of information and we were moving quickly. We will have these slides available for people afterwards, so no worries there. So Priya, over to you. And again, looking to stay within about 10 minutes. Thank you.
Okay, super. Thank you. Can you hear me? I just want to make sure that you can.
We can hear you, yes.
Perfect. Okay, so thank you to the organizers for inviting us, Track 20, and our colleagues in country to be part of this important webinar. Next slide. I start with this slide to recognize these colleagues, the M&E officers who work within government and from whom I have learned a lot on the complexities of implementing changes in health information systems, interpreting change, and especially working within the incentives of global and local systems. Next slide. So beginning with the context, so I was meant to speak on data use, data quality, but I think we need to understand the context of data use and quality. So the context within which HIP interventions can be monitored, most countries are using, as you know, DHIS2 for data collection and modest interpretation, and most host a wealth of family planning data elements, and as Deb showed, multiple disaggregations and indicators which pull denominators from DHIS2. It's important to recognize that there are different sorts of dashboards, because I think the inclination is to move towards dashboards to visualize HIP progress, HIP monitoring, etc. The dashboards within DHIS2 are usually single topic, static, and usually and almost always no information on data quality here. Other dashboards that represent visualizations or combined information tend to sit, as Susan mentioned, outside DHIS2, which makes it partner dependent. These do not automatically update with new versions of DHIS2 or indeed new definitions and new data elements, say for HIP measurement. Typically, these lack information data quality. This means that when a partner, so besides the data quality issue, when a partner leaves, the dashboard and its indicators linger without updates. We do have a new context with the availability of a DHIS2 application for family planning called FP Data Pro, which is available in the DHIS2 Play Store and is embedded within DHIS2, so can move with systems changes, can host specific modules, and more usefully generate reports such as ones that might include monitoring for a HIP indicator down to the lowest level. I think one of its exciting opportunities is that it opens up data agency to those who have to manage implementation and perhaps monitor implementation, but have limited access engagement with routine data. And finally, probably even more importantly, it has an entire module on data quality. So this is some of the new context within which a new indicator for HIPs and HIPs monitoring might occur. Next slide. In addition to what is there, there's an emerging context which could and should be considered as we think about data availability, quality, and use. This context is moving closer to EMRs or its interim step DHIS2 trackers, which enable us to get client-level data. HIE data environments are being planned or emerging, especially for HIV, and HIV partners are making choices when it pushed about what indicators are relevant for family planning. It is important that family planning programs are at the table when EMRs are being scaled up, so that FP indicators and data elements are included, or FP services indeed are included, and which then HIEs are being developed. Tomorrow you will learn more about how one country has moved with family planning first in the HIE space, so that we now have a new version of FP Data Pro that can be used in the HIE context. And this move to HIE and EMRs allows for standardization of indicator construction. So a lot of the differences in calculations, indicators, data elements that both Susan and Deb spoke to are being, are being eliminated through this process because of standardized protocols and what's allowed in these systems. This makes for improved data quality and also improved data use because you're allowing patient-level data to come into play. Next slide. The main point that I'm trying to make here is that countries use data, but that use is closely tied to leadership within the program and to the resources that a program has and what subnational levels are allowed to do. I pull out two countries here. Rwanda, which decided to adopt a muscular attitude to monitoring PPFP uptake, use, methods, and carefully moved its human resources and data resources to monitor FP. So it was a high impact practice, yes, but it was also of high priority to the government, a leadership priority. In India, where government resources are at play, not donors, the central government wants to carefully monitor the use of its money. So it uses PIPs or program implementation plans with states to carefully monitor uptake and performance down to the district levels. We may not all agree on the indicator choices that they make, perhaps, or the limitations by method, for example, for PPFP, but there certainly is, again, where the resources are at play, we actually see a different sort of use of data. Of note, we should, in most countries at the subnational level, data use is limited to what they're allowed to do. So really based on allowed, by that I mean what resources exist, what personnel exist, and it's mainly used to understand operations where possible. So limited amount of careful sorting on data quality related to reporting rates, timeliness of reporting, and perhaps training needs. And it's very unlikely the data is being used by facilities to manage and predict important things like client outcomes or client volumes, seasonality, for example, when to assign increased numbers of people, etc. Also to note, many family planning programs are relying on donors and partners, so they lack the agility to move resources to underperforming areas, even when they have the data at their fingertips to use. Next slide. So putting it all together, to get an indicator data element to the system, my first recommendation would be to work with HMIS insiders so that indicators are built based on usefulness, what the context that the country finds itself in. Is it in sort of a very nascent sort of system? Is it moving towards a more sophisticated sort of client level data system? And what kinds of resources and leadership exist? So indicators built on usefulness tend to be the cornerstone of quality. And I borrow from the PRISM framework here. If indicators are irrelevant to the leadership or to in general to the kinds of resources that are available, data collection forms are complex. This will certainly affect both the confidence level of people filling in the data and submitting it, but also affect the incentives, available motivation, and therefore the data quality. Other points that I think I'd like to make if I have time is essentially you learn about how one country is approaching, building, bringing in the private sector, where measurement, so even though this is a high impact practice, measurement and monitoring is not about a single indicator, but thinking carefully about the incentives of the private sector to report or not to report, and also the larger digital health strategy of the government. Here, I think, where the program leaned into the broader interest of the health information system, sort of thinking about what the future of the digital health strategy was going to be, then thinking about where, how the private sector data could be included, made it more likely that there was good data capture, both from the private commercial sector as well as the pharmacy sector. And in terms of the PPFP data, which was presented by Deborah, we see that there's a lot of breadth in the type of data elements, the location of data, where data has been collected, indicators constructed, etc. And what I'd like to suggest is this is reflective not of a lack of consensus on good indicators alone, which is what I think we are presenting today about the kinds of things that we think would be good, carefully constructed metrics for, in this instance, PPFP and PFP, but really the breadth in terms of what's being collected reflects the wide range in motivation and priorities of the national programs where we work. So going back to a previous slide, thinking carefully about really what leadership exists, what incentives exist for data use, and what resources exist will matter as much as having good indicators and good metrics on the table. Thank you.
Thank you, Priya. Thank you, Deb. Thank you, Susan. I think those were really helpful presentations for understanding, again, sort of what is happening out there within registers, within summary forms, excuse me, within electronic HMIS. That's fine. You can move to the next slide. Where do we see the flow of information happening, stopping, et cetera? And then with Priya's comments, kind of a little bit more context around why might that be the situation? What are the human and other resources that both facilitate or constrain the ability to see that information flow and then use it for decision making. So I will ask you all to keep those presentations and comments in mind as we now shift to our next session. I'm really thrilled that we will now be able to hear directly from several individuals who are sitting with that data in that context and can talk to us a little bit about their own perspectives around these specific globally recommended indicators and just the broader context of being able to monitor the scale and reach of these HIPs. So you'll see on the slide who our esteemed panelists are. I'll begin with our moderator, Dr. Emeka Nwachukwu, who's the Senior Research Advisor in the Office of Population and Reproductive Health at USAID. And he will be in discussion with Dr. Valérie Sanon, who is the Director of Family Health at the Ministry of Health in Burkina Faso, Dr. Charles Olaro, who is the Director of Health Services in the Office of the Director of Curative Services at the Ministry of Health in Uganda, as well as Dr. Bibek Kumar Lal, who is the Director of the Family Welfare Division in the Department of Health Services in Nepal, although I was just double checking to see if Dr. Bibek is with us. I'm not sure if I saw his name, but I will ask all of our panelists to go ahead and come off of mute or off and put on your camera if you're able. And Emeka will begin this conversation with you all. Thank you so much. Over to you, Emeka.
Thank you, Trinity, and thank you to all the panelists, Drs. Bibek, Olaro, and Shannon, for agreeing to be in this panel with all of us today. And we thank every one of you that have logged into this conversation. In the interest of time, we are going to start right into the questions for the panelists. I will start with Dr. Olaro and ask to please explain to us what stood out most to you in the presentation that we've just received and why they have stood out for you in this manner. Over to you.
Okay, thank you, moderator. I hope you are able to hear me.
Yes, we are.
Yes, first of all, thank you for the invitation. Overall, there is a deliberate effort by countries to track the HIPs as per the global recommendations. And it's something that's very commendable. And as a country, we really appreciate it. However, we need to note that it is not possible to track everything. As for a case of Uganda, the immediate postpartum and partially looking at the postpartum family planning, counseling is captured in both the antenatal and maternity registers. However, this information not reported in the monthly summaries forms, and such does not make it to the health management information system. This definitely is a missed opportunity for measuring the high impact as per the recommended indicators. We are also able to report on both postpartum family planning method provisions and immediate postpartum family planning provision within 48 hours of giving birth. And it's both recorded in the maternity register and reported both in monthly forms. So this makes into the HMIS, so the indicator can be reported at country level. However, the IPP method provisions can also be disaggregated methods except the condoms, which were not able to do it. We are yet not to include it in the monthly summary forms. So being able to track these indicators by method is very important to the government, but also helps in meeting country goals around the quality of care. The HMI forms are currently under review, and we should be able to consider to add condoms so that the full range of methods can be tracked. The new summary form to disaggregate family planning by use of timing method, but not age. This is a gap in measuring the health information, the high impact. Specifically, if you look at you are not able to address inequities. And I think we're looking at that probably instead of tracking counseling, it would be probably better to track the disaggregation in terms of age, but you still keep the data at the register level. Looking at the postpartum, post-abortion family planning, counseling is captured at the registers, but not at the summary forms. So this is also another missed opportunity in measuring the high impact performance beyond the facility level. So the counseling is not captured at register at the summary form. This is a missed opportunity for us. So it means that uptake is not captured in a disaggregated manner by all methods except by emergency pills in both the register level, except for condoms and emergency pills at the summary level, while this age disaggregation is only captured at the register level. So we are looking at now as a country to see how do we capture the condoms and also the emergency contraceptive use and the age at the summary level, which would enable us to measure this as per the definitions. So in a nutshell, we are looking at seeing some of the few changes which we are going to introduce, and so that we can be able to see that we are able to address the inequities in accessing family planning, both for postpartum and also for the post-abortion care. Back to you, Chair.
Thank you, Dr. Olaro, for identifying those missed opportunities and support that government could receive or provide in making sure that these indicators are captured for proper national reporting and program planning. I will pose the same question to Dr. Bibek if he's in here with us today. Can we confirm that Dr. Bibek is here, please?
Yes, he is.
Thank
Okay.
you, Dr. Najuku.
Thank you.
First, I would like to thank all the presenters for their insightful presentations, and it was interesting to note the large variation that exists in the indicators that are captured in both registers, as well as the reporting mechanisms, and also the duplication in the ways they are captured and reported across the board. So I was thinking that since it has been some time since the high impact practices have been recommended and countries are making changes in their programs as well as in their recording and reporting systems to better reflect their high impact practices in family planning, I think there still remains a lot of work done to standardize the recording and reporting indicators, because it's difficult to kind of measure or assess one program against the global or regional trend. So, for example, I was a bit surprised to see that still after so much of advocacy and so much of health information system strengthening, reporting in HMS is still exceptional, is an exception rather than norm, rather than the rule. So I think unless that is emphasized, and I understand that even within my own country, we are still working hard to ensure that all those high impact practices, both in postpartum as well as post-abortion family planning, are captured well. One thing that I saw that a lot of countries have been capturing, which we have not somehow prioritized, is the information on counseling. Because there were when we were revising our HMIS tools a year and a bit longer back, I think there was so much of debate on what would be the best way to measure or assess the quality of counseling. If it would just be checking the boxes to say that, okay, we have counsel, would that suffice? Or what would be the way to do it? So when I looked at the global comparison, we have not been doing so, but I think now we need to again sit down among our stakeholders and see how we can incorporate that in our recording and reporting systems. So I think for that, for now, I'll stop. Over to you.
Thank you, Dr. Bibek. You've noted some advocacy issues and HMIS gaps, especially important for your country. And I know some other country officials here might be recording the same types of gaps that might have implications for HMIS reviews. And we hope that some of those things will be taken away from this meeting. I'm going to ask Dr. Sanon to respond to the next question. Dr. Sanon, thank you for coming. From the presentations we've had, which of the globally recommended IPPFP and post-abortion family planning indicators feel relevant to your country, and which of them do you think do not? Over to you. Dr. Sanon?
Oh, yeah. Bonjour, Dr. Sanon.
D'accord. Merci pour la parole et merci également pour cette invitation. Je voudrais vraiment traduire ma reconnaissance à tous les intervenants pour les riches informations dont nous avons bénéficié sur la planification familiale du postpartum, post-abortum, et dire que je suis très, très honorée de partager l'expérience de mon pays avec vous à travers ce panel. Donc, il faut dire que tous les indicateurs qui sont recommandés, que vous avez présentés cet après-midi, sont intéressants car ce sont des indicateurs qui facilitent la prise de décision et permettent une bonne planification. Mais moi, je vais vraiment m'attarder sur les quelques-uns. Donc, les indicateurs planification familiale du postpartum et post-abortum. Ce sont des indicateurs qui sont pertinents, que nous utilisons dans notre système de santé. Et au niveau, en tout cas, des portes d'entrée pour ce qui concerne les différentes consultations, nous avons mis en place des registres pour pouvoir collecter des informations. Donc, au niveau de la consultation prénatale, consultation postnatale, salle d'accouchement, etc., ces informations sont compilées, analysées et également exploitées pour faire la planification de nos activités et prendre les décisions. Et aussi, nous avons vraiment apprécié la désagrégation de ces indicateurs par groupe d'âge et par méthode, car ça permet vraiment d'affiner en tout cas les données et de mettre en évidence les disparités d'adhésion pour ce qui concerne les jeunes mères et celles qui sont âgées. Mais toutefois, il faut le dire, cette désagrégation en âge inférieur à 20 ans, supérieur à 20 ans, ne permet pas vraiment d'apprécier l'utilisation des services de santé par les adolescentes. Je veux parler de celles dont l'âge est en tout cas compris entre 15 et 19 ans et qui, en tout cas, une contribution importante à la fécondité au niveau de mon pays, puisque c'est autour de 117 pour 1000 naissances. Et également aussi, ça ne permet pas d'apprécier, en tout cas, les données pour ce qui concerne aussi les jeunes femmes âgées de 20 à 24 ans. Et ces données-là, ces données spécifiques aussi ne sont pas disponibles au niveau de notre SNIS. Et ça nous permet vraiment, ça ne permet pas de nous faire une idée sur ces personnes en termes, en tout cas, de besoins, en termes de leur adhésion en planification, et ça rend difficile la planification en faveur de ces adolescents et de ces jeunes qui, malheureusement, le plus souvent sont, en tout cas, viennent nous voir dans le contexte d'avortement, grossesse indésirée. Et également aussi, le fait de suivre ces indicateurs par méthode, nous pensons que c'est très intéressant et nous avons la possibilité d'apprécier ces indicateurs par différentes méthodes et voir quelles sont les méthodes qui sont les plus utilisées, soit par les jeunes ou bien par les personnes âgées, et voir aussi en termes de méthodes de longue durée, lesquelles sont en tout cas mieux utilisées, et ça nous permet d'orienter en tout cas nos counseling, les conseils pendant les consultations, pendant dans la salle d'accouchement, et vraiment d'offrir des services. Et aussi, il faut dire que les informations pour ce qui concerne les femmes qui ont bénéficié de counseling durant la période de grossesse ou bien de counseling même sur la planification familiale de postpartum, là. Généralement, c'est saisi au niveau de nos registres et pour le moment, nous sommes en train de travailler pour que ces indicateurs-là puissent quand même être pris en compte dans notre système d'information sanitaire parce que ça permet de voir le travail que les prestataires, en tout cas, fournissent pendant les consultations pour offrir les informations et également aussi, ça nous permettra vraiment de prendre des décisions en termes vraiment d'améliorer ces counseling-là. Donc, nombre de femmes ayant reçu de counseling et si on rapporte au nombre de femmes qui ont pris, en tout cas, la méthode soit après l'accouchement, soit après avortement, ça va vraiment nous donner une orientation. Et toujours pour ce qui concerne vraiment tous ces indicateurs-là, il faut dire que ces indicateurs, en tout cas, sont tous intéressants pour nous. Donc, les indicateurs qui ne sont pas encore compilés au niveau de notre système d'information sanitaire, vous comprendrez que pour nous faire une idée, il faut des enquêtes. Donc, des enquêtes pour voir l'adhésion, par exemple, de nos adolescentes à la planification familiale du postpartum ou bien leur utilisation des services de planification familiale après les avortements. Et nous ferons en tout cas le nécessaire, c'est-à-dire le plaidoyer pour qu'on puisse rendre disponible afin qu'on puisse améliorer notre prise de décision. Encore merci à vous. Merci d'avoir associé le Burkina Faso à cet important panel. Merci.
Thank you. Thank you so much for the great insight you provided here and the commitment to improve on your data collection. And most importantly, the opinion on disaggregations, which will form part of the discussions in the breakout sessions that will follow on immediately after this panel. I want to thank all the panelists for being here, for your insights and all the conversation we've had. I will now hand it back over to Trinity for the next sessions. Thank you.
Thank you, Emeka, and thank you, Dr. Bibek, Dr. Sano, and Dr. Olaro. That was very interesting, and I think helped probably many of our participants to further get into the frame of mind of what seems feasible and desirable within the context of a given country or a given program. Very helpful now as we shift into the most exciting part, which is the breakout group discussion. So if we can go 2 slides, please, Emily. Perfect. So really, this is our opportunity now to take stock of everything we've heard and speak to each other to advance this discussion on ideal indicators for global monitoring of HIPs. And specifically, we've been referring to these globally recommended indicators that exist for IPPFP and PAFP. And we want to really put on the table, create the space for you all, as our panelists just did, to say, yes, this makes sense. Yes, this makes sense, but we recommend this type of change, or no, this doesn't make sense. And think about how we continue to move the discussion ahead. So we will be breaking out momentarily into groups. Many of you pre-selected a group, and so you will be placed there. If you did not pre-select a group, you will be randomly placed. So apologies, but I'm sure you will find it very interesting. And within each of those groups, we already have a designated facilitator who will guide us through the discussion, and a note taker who will be capturing the key points on a Google slide. And we will ask each group for someone to volunteer to be a rapporteur, so someone who will come back and share one conversation point with the larger group in plenary when we return. So we really hope that this will be an opportunity for you to share your own perspectives with each other, and again, help us move toward the idea of some consensus, if we can achieve them, around specific globally recommended indicators and their disaggregations. I will just make one note about the timing. We are at about 10:17 my time. We're running just a few minutes late, but that's okay. We will still take the full 45 minutes in breakout groups, because this really is where the magic happens. So we'll stay at 45 minutes. Our facilitators will let us know when it's time to come back. So please make sure you don't run out of time to identify who is reporting out and for them to feel comfortable doing so. And with that, I will ask Sarah Dixon to go ahead and assign us out to our breakout rooms. So enjoy the discussion, and we will come back together in 45 minutes. Thank you.
Shannon, Emily, do you guys want to go to a room or you want to just take a break and breathe? I think I need to breathe for a second, but
Please
but
do.
then but then I can go into maybe a PPFP group.
Okay, you just let
Um,
me know when, and then I'll move you. Not a problem.
It seems like Rogers isn't able to
I got him.
report. Okay.
He was on 2 accounts, so I had already
Oh,
done one, and I guess he was anyway. So I had to join the group, but he is now able to. report.
okay. Very good.
Yes.
Very good.
Ooh.
So then you can send me into a PPFP group.
Okay. Well, you just join whenever you're ready, okay? But I'll go ahead and assign you a
Okay.
PPFP.
Thank you.
Oh, you're so what? Thank you.
welcome back, welcome back. All right, I know we're getting everyone back into the main room. It's always an abrupt end to fruitful discussion and a little jarring, so sorry about that. We may have lost some people along the way, which is understandable, but hopefully we still have somebody from each group to report out. We do not have a lot of time, so I will ask that people keep their report outs quite succinct to 2 to 3 minutes. And I'm going to call on the groups in a particular order, and I will start with IPPFP and group number 1, which had Rogers as the facilitator. Would the designated rapporteur please come off of mute and share your responses to the discussion question 3, which was related to the indicator on method provision and uptake, in 2 to 3 minutes, please.
Thank you, Trinity. I'll invite Sarah, who's been our note taker, but also the rapporteur to take on this.
Yes, thank you. Thank you for the opportunity, Trinity. So I'll take you through the discussion question 3 about the indicator on uptake, right, Trinity?
That's correct.
Yes, so by and large, there is agreement that the indicator is still relevant and helpful because it's much easier to capture and it can tell you what is actually happening at the time of delivery. However, we need to include LAM as a part of methods that are being tracked for this indicator if we do methods disaggregation, plus other short-term methods. Inclusion of LAM can drastically change the indicator and its interpretation. The disaggregations are still relevant. We can look, but we also have to look at regional and regional geographical variations as a proxy to access by method. We need a follow-on indicator to track mostly the lax removal, but also other methods continuation. The age group above 20 is too broad, which confounds cohort or subgroups performances for the PPFP, and there is a need to break this further, and this may be context-based. That is
thank you.
Precisely what we have from that group.
Okay.
On that question, yes.
That was excellent. Thank you for staying in time. It sounds like you all were very eager to add some additional data and indicators. So thank you for that. I'll hand it now to the second IPPFP group with Emeka as facilitator. And because I was in that group, I know Janine is our rapporteur. So over to you, Janine.
Okay, thank you. I was not the note taker, so I don't know if we have notes that we were going to share for that, or I can just quickly summarize our discussion. We had an interesting discussion. I'm not sure we came to any consensus around the indicator. We agreed that it's an important indicator to capture. It's a good process indicator. It can be very helpful at the facility level to ensure that they're providing an essential service to women, and all women should be counseled on family planning. And it can also serve as a quality indicator. And it, you know, women's decision to take family planning is often influenced by their partner and other considerations, and sometimes they don't make decisions right away. And so by measuring this, we can ensure that all women at least were given the information and had counseling on it, and then they can make the decision to uptake a method either at that time or at a later point in time. And at the same time, you know, in terms of rolling the indicator up, you know, there's some system considerations what the system can handle. And that's especially important when you're looking at those disaggregations by method and age. And so there was maybe some consideration that maybe age would be more important than method, and particularly maybe some age groups more important than others even. And I think that's, I can leave it at that, and others can add if they would like. Thank you.
Thank you, Janine. I think for the sake of time, we'll go on to the next group, but interesting to note that there was less agreement in that group. So we'll hear how it goes for the counseling groups now, moving on to post-abortion family planning. But the first group for post-abortion family planning, Bethany, as facilitator, you all are reporting out on question 3, which was again about method provision. So over to your rapporteur. And I'm sorry, we had hoped to allow the note takers to share the screens and are having a little trouble with that. So if the rapporteur isn't comfortable and you'd rather the note taker do that because they have the information in front of them, that is also okay. So not sure, Bethany, in your group, who was selected as rapporteur.
Trinity, just a quick jump in that Fred facilitated that group.
Oh, I'm sorry, Fred. So, okay.
No problem.
So then,
sorry. Yeah. So thank you very much. Our rapporteur was Gandhi. Please. Melissa took the notes. Gandhi, go ahead, please. Thanks.
Yeah, so our group spoke about age and method disaggregation, and we agreed that both age and method disaggregation for post-abortion contraception is important. But there's also a little discussion around potential stigma if there is age-based disaggregation, especially for the younger cohorts. A minor discussion around potential for missing out non-facility clients, clients who are getting medical abortion outside of facilities and missing out on the post-abortion contraception for them. And there was an observation which was to look at ways of verifying this, that there's currently no evidence on variation by age on post-abortion contraception uptake. So we need to be mindful of that. And everyone kept going back to the country panel discussion that we could keep adding indicators, but we have to be mindful of the results that it's getting us. So that was the discussion around the age and method disaggregation. So there were clearly no doubts around method disaggregation. Everyone agreed on that. On counseling, everybody agreed that it's an important indicator to include because it offers you an opportunity to understand choice, informed choice, as well as quality. There was a discussion around capturing counseling by age, but the group was sort of divided again on that in terms of how to measure that, what impact is that going to give us, and again, how easy or difficult is it for countries to get that information and ladder it up. So one suggestion was to possibly document that at the register level and not necessarily ladder it up to the HMIS level, but look at other evaluation methods to look at the age disaggregation in counseling if the group, if we get to that point. I'll pause there.
Thank you, Meda. That's interesting. Again, I think we're all excited and want to add indicators, but I appreciate that y'all were also thinking about where you may have to make some strategic choices about what information goes all the way up. So I believe then that was the only post-abortion family planning discussion group. So if that's the case, then I will shift to the broader postpartum family planning discussion group. I believe that then group 1 had Erin as the facilitator. And so I'll ask that rapporteur to go ahead and share.
So, and Jennifer Wanyana is our rapporteur, if you're comfortable. And if not, Elena has the notes.
Please let the note taker present the notes. Thank you.
Hi, Jennifer, I did chat you all the information, but that is fine. Okay, so we're presenting on our, hold on, let me make the notes big enough so I can actually see them. Okay, So we're presenting on PPFP. First off, what time period do we think PPFP should cover? So we didn't really come to a firm conclusion. We have a couple different ideas. So one kind of blanket is up to 1 year after birth. And we also talked a lot about like how to like different time periods. So aligning with child vaccines to make sure we could actually measure it. So it seems like different countries have different time periods where they do the vaccines, but it ranges from like, weeks to months, just depending on the country. So first 3 weeks, first 6 weeks, 10 weeks, 14 weeks, 9 months, et cetera, et cetera. We also discussed how it's going to be really important if we're going to make a PPFP indicator that it doesn't overlap with the IPPFP indicator. So we can measure these two concepts separately. Excuse me. Then talking a little bit about our suggested indicators. We also didn't come up with a firm one, but we did come up with a few. So one would be the number and percent of women attending routine immunization services to follow through on a family planning referral. So linking it to immunization services. Another is the number and percent of women attending postpartum services who receive family planning. And so receiving family planning would mean that they got counseling and received a method. Then another one is tying it to just general services that women might receive. So the number and percent of postpartum women who follow through on a family planning referral from other sources. So it could be like cervical cancer screening, nutrition counseling, maybe a sick visit. So there's a lot of different ways we could capture women that way. Then we also talked about disaggregations. So we thought age disaggregation would be particularly helpful. And of course, what family planning method? And then finally, the denominator. Again, we don't have a firm denominator, but one is the total number of postpartum women of reproductive age who have recently given birth and are at risk for an unintended pregnancy. Another thing we talked about is linking it to the number of expected deliveries at a facility, since it can be hard to measure the actual denominator. So if you could look at like what we expect, that would be helpful as well. So there's a few more things, but I think that's enough for now. Thank you.
Thanks, Elena. Thank you to the first group. It does sound like you had quite extensive conversations. So happy to hear that you were able to move into all of those different areas. I believe there was a second postpartum family planning group. Althea was facilitator. So I'll ask that rapporteur to go ahead and share.
Of course, Nihal was our rapporteur, so I'll hand it over to them. Thank you.
Thanks, Althea. Hi, everyone. So we discussed in our group some of the challenges around capturing that data, issues around sort of reconciling, capturing postpartum family planning data, specifically on the client level across different registers, and avoiding duplication and overlap, issues around connecting the various sort of facilities, be it community or other facilities, distribution of services, the timing as well, that countries are not necessarily are all aligned in capturing the data across the specific time frames, be it 6 weeks or 6 months or 1 year. Also issues around if the indicators, how they're structured specifically in terms of timing, and if there is a lot of political commitment behind sort of meeting those indicators, how does that impact the quality of service that is being provided by the providers, and if they are if that pressure, be it or political pressure, can impact the decision making of the users, and issues around coercion. We also discussed if when the guidelines changed, be it, for example, when the WHO MIG guidelines got updated, how or what, when did the national guidelines sort of adapt to these changes, be it around timing or contraindications around long-term acting contraception, postpartum or post-abortion, and insertion of those methods, and how these kinds of variation in taking up the guidelines quickly does impact the reporting. We also discussed some other sort of, not necessarily recommendations, but issues that we raised were also around encounters at the family planning sort of clinic, and to what extent are really systems capturing that time-specific data, and how that is very varied between the NGO providers and the government providers in terms of registering this data on DHIS. Also the challenges related to the denominator, so that also speaks to the reconciling the data from different registers, but also recognizing that this duplication is important, specifically because we know that there could be some high rates of discontinuation or switching across methods, and that could affect the quality of the data as well.
I'm sorry, I'm going to have to ask if you could just say one last point, and then we have one more group to report out.
I think, we wrapped up the discussion more around if DHIS is the sort of, is the best way to capture this kind of data, or we can look into other systems or other available evidence. I'll stop here. Thank you.
Great, thank you. Again, another really wide-ranging discussion. Sounds like we didn't necessarily reach consensus on different points within the PPFP group regarding that kind of set indicator, but had a lot of fruitful discussion. We did have also a French language discussion group, so I will ask JC as the facilitator to please invite the rapporteur.
Thank you very much, Trinity. We first had to select one HIP. So the team almost unanimously picked the IPPFP. I don't know what that tells us today. So I'm going to hand over to Dr. Valérie Zombré to report. À vous, Dr. Valérie.
Merci beaucoup pour la parole. Donc, au niveau de notre groupe, nous avons beaucoup échangé autour de la PFPPI en termes même de pertinence pour ce qui concerne cet indicateur. Nous avons tous trouvé que c'était un indicateur qui était en tout cas pertinent, qu'on pouvait toujours continuer à faire le suivi. Maintenant, pour ce qui concerne les questions de désagrégation de cet indicateur, nous avons ensemble convenu qu'il fallait encore, en tout cas, penser à un autre groupe. Au lieu de se limiter la tranche d'âge inférieure à 20 ans, et 20 ans et plus, on pouvait prendre en compte, en tout cas, la tranche d'âge compris entre 20 et 24 ans pour pouvoir avoir une idée pour ce qui concerne les adolescentes enceintes qui viennent consulter et qui demandent des services. Également aussi, nous sommes tournés sur les éventuels défis qu'on pouvait rencontrer pour ce qui concerne la compilation de cet indicateur. En termes de défis, il y a d'abord les accouchements à domicile et également aussi les contextes sécuritaires qui limitent l'accès aux services de santé. Il y a également la charge de travail qui peut amener les acteurs à oublier d'enregistrer les données au niveau du registre de consultation. Et un autre défi, c'était vraiment l'absence ou l'insuffisance de compétences pour pouvoir offrir la contraception choisie par la femme. Donc, c'est de parler de peut-être les implants, les dispositifs intra-utérins. Donc, voilà en tout cas résumé les informations dont nous avons échangé. Et comme c'est tout un groupe, je demande aux autres de compléter si éventuellement il y a eu une omission. Merci à vous.
Thank you, Dr. Sano. So again, some interesting discussions around age disaggregations, but also some of the challenges, particularly how to account for those non-facility-based births. I know that it is very challenging to synthesize those discussions in just a few minutes. And so we're really happy that we were able to record, I think in most cases, those discussions so that we can kind of synthesize those and share back out in some way, shape, or form with all of you. So thank you for sticking around and participating in the discussions and for sharing your insights and experiences. We are now shifting to the very end to next steps and closing. And so next slide, please. I will introduce and invite Maria Carrasco, who's the Senior Implementation Sciences Technical Advisor in the Office of Population and Reproductive Health at USAID, to just share a few closing remarks. Maria.
Wonderful. Thank you so much, Trinity. And thank you everyone who made today possible. It was a tour de force in terms of measurement. But most of all, thanks to each and every one of you for spending the last 2.5 hours with us in these important conversations. The HIPs are the high impact practices in family planning are a public good, and they are possible through colleagues like you who are willing to put forth your time to share your expertise and knowledge and experience with others so that we can make these resources widely available for the family planning community at large. There were rich conversations today in the discussion groups, and I know that the R4S colleagues and all of those colleagues in the committee who are working to help us identify final indicators will have a lot of data to go through to come to final deliberations. On that note, they will be sharing information of from this meeting today in the future, so stay tuned. And then they'll also be sharing more information of how to stay engaged with this activity as well. So thanks again to everyone who participated today. Back to you, Trinity.
Thank you, Maria. Yes, so just another huge thanks on behalf of the Planning Committee and all of the organizations who are a part of that, and inclusive of the HIP co-sponsors. I really hope that this was interesting, and for those of you who stuck it out, bravo. 2.5 hours is not a small amount of time. So as Maria said, please do stay tuned. We'll be in touch to certainly share the links from today's webinar and presentations and some follow-up resources, but also to engage with you all as we do continue to advance the discussion around these globally recommended indicators and how they might change to further serve all of our goals and objectives. So a big thank you. 5 minutes to spare. Enjoy the rest of your mornings, afternoons, and evenings. Thank you so much.
Great. Thanks.